Peter, can you hear me?
Oh, sorry, I was muted. I can hear you.
Okay.
Can you see my screen?
Yeah. Okay. Welcome everyone to the STR. Peter's going to start us off this week. Go ahead, Peter. Thanks.
Hey guys. So today I just have a few. Actually, today my cases are, I think, all vascular. So a few cases. The first one, this one, I was reading, consulted one of our colleagues, and we noticed some strange-looking structures up here, curvilinear. And this patient also has an Impella device, and the Impella looks okay. And it's one of these Impellas that are put in through the axilla, right axilla. So the question is, what are these? And we have a chest radiograph, and you can see them there. Do you guys see these at your institution, Howard? This type of stuff?
Axillary Impella device?
Yeah, well, the axillary Impella, but I'm talking about these curvilinear things, because we hadn't seen too many of these. Do you see what I'm pointing at? Like not the surgical clips, but this serpiginous.
So I do see the Impella, but I also see what appears to be skin staples.
Yeah, skin staples, and then this curvilinear stuff here.
As well as clips as well.
Yeah.
So I don't think I've seen that combination of a skin incision with those curvilinear things and the surgical clips in the context of an Impella device that I recall.
Right. And here are these funny looking curvilinear things here that we were seeing. So we were wondering what that is. We looked at the op report, and for the Impella, because this all coincided with the placement of the Impella device. So basically they, unfortunately we don't have contrast, but they put a gel weave graft, they connected a gel weave graft to the axillary artery through which to thread the Impella. And there was bleeding, so they used vessel loops to control the bleeding. So these are vessel loops, these curvilinear things, retained vessel loops. We get called by the OR a lot because to see if they're retained vessel loops. We usually don't see any. This is like the first time I saw. I think these are intentionally retained vessel loops. A lot of times they're looking for accidentally retained vessel loops.
So what are vessel loops, please? Are these wires or something?
They're let me show a photo of it. They're like they're silicone, these silicone wires that are used for different surgical purposes, but they could be used for to tie off vessels or for so vessel loops.
Huh.
And then these are some of the functions of these. So sometimes they could be used for retraction. Sometimes they use multiple purposes, basically for tying off vessels, closures.
You know, that's interesting because I think I remember reading op reports in a general sense in relation to, say, cardiac or other intrathoracic surgical procedures in which the op note describes the use of vessel loops, but not opaque on imaging that I know of. But these are obviously opaque.
Wait, I've heard also that they're not opaque, but then these are obviously opaque and they're made out of silicone. And then when I Googled it, I saw it said that they're radio opaque in one of the things. So I think they could be either.
Okay.
Sometimes when we get called by the OR, they tell us, oh, they're not. We just have to call you guys, but it's just a formality because they're not radio opaque. So it's
Right. So some are and some aren't. Oh, yeah. I would not have recognized that because I don't think I've seen an opaque vessel loop or loops like that. Oh, that's interesting.
They
Yeah.
probably impregnate them with something containing a, barium or iodine or something like that to make them opaque, because
Well, the silicone I would have thought would
it
be.
would not be that bright.
Mm.
Yeah.
Oh, that's interesting. Oh, that's useful to know. I don't think I've seen that.
Mm-hmm. Okay, David, this one would be a good one for you to weigh in, because I think I showed one of these before, and you have experience with these. So this patient has a history of syphilitic aortitis, and what do you think about his ascending aorta? Is this amount of calcium? Do you think that's?
Well, the question is, what procedures has he had? Is there a graft in place here? Are we
No,
seeing
he
some?
doesn't have a graft. I think he just has a cabbage. He just has a cabbage, and I don't.
Yeah,
And probably old history of it. So.
yeah. So, I mean, this is, sometimes you can see really heavy calcification. And generally, atherosclerotic calcification is descending aorta over ascending aorta. With syphilis, you can get a lot of ascending aortic calcification. So this is a modest amount. I think it doesn't leap out as being,
Yeah.
that different from ordinary atherosclerosis.
Yeah, you can kind of see some circumferential thickening here that's non-calcified.
Right.
But there's definitely, yeah. So typically with the syphilis, you're looking for a lot more.
Well, that was the striking finding, but probably in those days when we were actually seeing that, people hadn't had treatment. So syphilis may have been treated and maybe didn't get to be so advanced that you had that really intense atherosclerosis. So depending on the availability of medical care, you might not reach that florid state anymore.
Okay. And then the other two are kind of related. This one is fresh from today. I got called about it from the scanner by one of the cardiologists who's this patient. So the cardiologist had just done a stent placement, angiogram and stent placement, and so what he saw on his angiogram after he placed the RCA stent is what he thought was a dissection. So contrast seemed like it was dissecting into the ascending aorta. So here's the CT scan. The initial one that he did, he called me from the scanner and it was not gated. So you can see something here, which can be very easy to blow off if you have no history or nobody's talking to you while you're reading this. You could easily blow this off as motion artifact on a non-gated scan. And there's also a non-con at the time.
Oh.
So you can see the con there. So this is so exactly what he saw is what we're seeing here. He saw on his angiogram, he saw a type A dissection, like a limited dissection. I also noticed when I was looking at this, I didn't really like this RCA stent looked a little too misplaced, meaning that it seemed like it was jutting too much into the aorta, right? Especially on this view. So on this view, it's kind of, you could argue, is it for motion? But I thought I wasn't really comfortable with the way it was. So I just told him to repeat it while the patient was still down there is gated. And so we have a follow-up. The other interesting thing to note on this one is the way he also noticed that on the angiogram is that the contrast was he saw it going right into the right along the edge into the pulmonary artery. So it kind of goes along with the shared sheath of the aorta in the pulmonary artery. A little bit of contrast here, but he noticed that he said it was more impressive on his angiogram, which unfortunately the angiogram images don't go to our pack, so it would have been too hard for me to get them. But so here's the follow-up just, I guess, 10 or 15 minutes later. And it's supposed to be a gated study, but it's not well gated. But it's, again, you see the little dissection there, actually not as well, actually. And the stent was misplaced. It was coming into the lumen of the aorta, which he agreed with, and he said they would just adjust that. He said it was an easy adjustment.
Oh, so that's very nice. Can you show us the one where the contrast goes into the shared sheath and maybe even adjacent again and zoom in? That's really interesting.
It'd be most interesting to see the angiogram, but yeah, you can kind of see it right there.
Ground glass, 930. Medial.
Oh, that's really interesting.
Right below.
Is there any hint of it at all in the actual recess of the pericardium next to that area?
I don't think so. I didn't see pericardium. It wasn't very much, but
no, it wasn't much.
No, it was a small dissection. And then the question was what to do with this. I don't think this is just going to be followed. And I don't think there's a surgical intervention here that necessarily just going to be followed. Patient is kind of doing well the day after, so just watch them and get a follow-up in a few months. Hopefully it's resolved. And then the other case I have is a companion to this. I read the follow-up. I actually probably showed this one last year, but earlier this week, I read a follow-up scan for this patient. So I'll just show the follow-up scan here. But I'll go back and show the original scan from. So this one is from. This is the one I read today, a few days ago, and then this is a follow-up from one I think I shared last April, 2021. Wait for this to load. So this is the scan, the initial scan I read on this patient. So you can see this abnormal. The question on this was it a vasculitis? But this was actually not a vasculitis. So all this stuff here is hemorrhage, the soft tissue encasing the pulmonary artery, and you can see it encasing the ascending aorta there.
And
so this is a non-gated study. This is a type A intramural hematoma. A lot of times they have a small intimal entry tear in the ascending aorta, which is actually right there. Also easy to overlook on a gated study, but this is not motion, that's real.
Yeah, these can be really subtle. So you have the blood and you have the intramural. Is there also intramural blood in the pulmonary artery wall?
Yes.
Yep.
There's blood right along the vessel that's sheared into the pulmonary sheath there, and then it's also along the ascending aorta.
So we have a so-called limited aortic dissection involving the proximal ascending aorta.
Mm-hmm. The non-con wasn't super helpful as far as seeing the hyperdense crescent from an IMH on this one.
No.
You can see that. And then we had a few other follow-ups, which in the meantime, but they already showed result, but I'm going to show the most recent follow-up, and you can just see the small little scar from the intimal tear, but all the blood has essentially resolved. This is probably just maybe just some fibrin or granulation here from the prior, but it's essentially resolved. And then all the hemorrhage around that's sheared along the pulmonary artery is also resolved.
That's really interesting because typically, if one is confident of the diagnosis, this is a patient that would typically go to surgery for surgical management of a type A limited dissection. But I suppose there are situations where these can heal without untoward effect.
Yeah, yeah, and I guess if they're really small, I think there was some some data on these limited ones that they could be medically managed or followed, but I'm not sure. I think it's just still controversial with whether it should be.
Right. I think that, and I can't remember if the one you showed before had some hemopericardium, but if you see ancillary findings like hemopericardium, some mediastinal blood, blood in the shed sheath of adventitia, it makes one pretty nervous about just overlooking this or just following it up. There's a really nice, I don't know if you attended the STR, but Costa Raptis gave a really good talk on difficult to diagnose dissections, concentrating on so-called limited aortic dissection. And typically at his institution, if they make that diagnosis, the patients do go to surgery.
I didn't listen to his talk, but I think they published a Radiographics article.
Right,
recently.
exactly. And he talks about that in that article as well. Yep. Oh, that's really interesting. Yeah. Nice.
I think those are it for mine. Yeah.
Okay, good. David, I'm going to, if I can figure things out here and get things back to where I want to be. I will make you presenter. Just give me a moment.
Okay.
All right, you should see the invitation to be presenter. Good.
Okay. So here is a chest radiograph on a person who has had bilateral lung transplant, has lots of diffuse lung disease and dense basal consolidation, has right pneumothorax, has a bunch of tubes in place. This has been going on for a long time. This person's not doing well after transplant, had a tracheostomy tube, has a feeding tube in place, which goes down the mediastinum, loops in the fundus of the stomach. So that was then, and that was on the 5th. And here's later on the 5th, they redid the enteric tube, and now it swings over to the right and then heads to the left here. And its position is ambiguous. I think my first assumption seeing this would be that it's still in the stomach. Little gas collection here in the pleural space, or maybe in the pericardium. I don't remember how long it had been since the surgery. We still have pneumothorax on the right, but this is a different course now of the feeding tube, and a CT scan was performed shortly after that, radiograph. Here's our tracheostomy tube, and here is a feeding tube, which seems to be in the airway rather than in the esophagus. So it comes down, and then this is the site of the right bronchial anastomosis. It seems to penetrate the wall, and then it swings over to the left. Here it is heading to the left, and it actually ends up in the pericardium. So this feeding tube went down the airway rather than the esophagus, ended up crossing the anastomosis, probably not doing it any good, and with tip in pericardium, surprisingly. So when they do and the gas is in the mediastinum, or actually in the pericardium itself. So not the world's most desired result here for feeding tube placement. And here it is on coronal swinging across there to the left. So it was just on top of the diaphragm. It wasn't in stomach. I don't think I would have picked that up from the radiograph. I was only shown this after the fact when Karen Ordovas was reviewing the CT scan. She showed me the whole thing. Okay, so less than ideal result of feeding tube placement. Here's another person with a funky enteric tube. So we have an enteric tube coming down like this. Instead of continuing downward toward Mr. Stomach, it swings off to the right and actually seems to have a tip that could be in lung. This person has a pleural drain in place, and there is a medial lucency here, which is hard to make out on plain radiographs. But let's look at this on CT. And here is the enteric tube in the esophagus. So this one is not in the airway, it's in the esophagus tracking down. And then it goes out laterally and ends up in this medial pleural space here. So this person has a known esophago-pleural fistula. And this tube is intentionally placed into this cavity to help drain it, help keep it clean, get material out. So this was intentional, but kind of a striking position of the enteric tube here on the plain radiograph. So this would cause one to want to look at a CT scan and find out what's going on. Why is it swinging off to the right like that? So it turns out that there's history here. This goes way back. And so let's pick up the earliest radiograph that we have, which is way back last June. It turns out that there's already a bit of a mass here in the mediastinum or hilum. This is a rather dense upper mediastinum here. This turns out to be abnormal. And then there's a component here, a hilar component. This was not readily picked up. Then there's too much something here below the left bronchus. Normally we don't have this much tissue down here. So 3 months later, September, things have gotten worse. You can see there's more upper mediastinal widening, and now there's this big blob of stuff down here with a fluid level in it. That looks kind of scary. And here's our fluid level back here. So the question is this a lung abscess, or is this something in pleural space at that point? And here's CT from September. And you can see that indeed there is a mediastinal mass that seems to be everywhere. It's on both sides, a lot of subcarinal stuff. And then there is this pleural fluid collection here with lots of gas bubbles in it, and collapsed opacifying lung here. So most of this abnormality here in the right base is in the pleural space. A big mediastinal mass here. So people wondering, is this just all inflammation? It turns out that this was Hodgkin's disease, and Hodgkin's disease had already created at this point an esophago-pleural fistula, and there's fluid down there and gas as well, probably gas coming down from the outside via this fistula to the esophagus. So this was presentation. At this point, there was eventually biopsy of this material and led to the diagnosis of Hodgkin's disease. So what we're seeing currently with that funky tube placement is drainage long after the mediastinal mass has shrunk down from treatment, and this person is left with this chronic esophago-pleural fistula, now managed with just a couple of drains and so forth. I think pretty well sterilized. But this was the cause of the whole thing, this big Hodgkin lymphoma.
Gosh,
okay, so
that's
funky.
bad luck.
Yeah.
That's unusual to present with an esophago-pleural fistula at the time of presentation. Gosh.
Yeah, and people were not really tumbling to the presence of a mass. I think they thought when they first encountered this, the person presented with lots of inflammation, and they presumed they were dealing with infection here, maybe mediastinitis and abscesses and things like that. They weren't that sensitive to the possibility of tumor. But once things settled down and they were able to then pursue diagnoses, they identified that there was tumor behind all of this. And I think, in retrospect, you can see signs of tumor on that earliest radiograph from June, 3 months before this more dramatic presentation. Okay, Howard, those are the only two cases I have gotten ready this week. Thank you.
Okay. Sure. Before I let you go, David, can you show us a little bit more, maybe on this one and the previous? Is there, I'm just curious, left internal mammary nodal disease? Well, there's nodal disease in other places too, never mind. Okay, in the mediastinum. Okay.
Yeah, I wouldn't
Lower
be
down, I
surprised.
think there was something, but I can't remember where I saw something.
Something here. What do you think?
A little bit, yeah. Was there, yeah,
There you
there's
go.
nodal disease there. Was that present on that pre-op, on the first CT? Just curious.
This is the first CT.
Oh, sorry, I got my timing wrong. That's interesting. Got the timing wrong. So that's nodal, internal mammary nodal chain, and then all that other. Wow, that's unusual, isn't it?
Quite a bit of stuff up here too.
Yeah. Gosh. Okay.
Okay,
Thank you.
thank you.
Okay, let's see if I can get back to seeing the screen like I want to. All right. Well, here is an interesting case that starts off not necessarily quite in order, but here we go. So take a look at this radiograph. See if you see anything interesting. Give you a moment, and then I will zoom in on the interesting region, which is going to be here. I'll zoom away in there and check out these items. And anyone can chip in here, but what are these reminiscent of?
Fibrotic.
Yes, sirree, Fibrotic. Look at them, round things, somewhat peripheral calcium, central calcium, peripheral there, Fibrotic. Well, that's unusual. We see those in the pelvis and we say, okay, Fibrotic are there. So supraclavicular. Wow, interesting. So they ought to be what right there? There ought to be something right there. That is that.
Lost by me.
So there they are, and we can see that the abnormal opacity is admixed with supraclavicular fat, but there's a substantial component of fat between the structures. And in some locations, one can readily imagine that some of these are tubular or dilated tubular structures within which the calcifications are located. So this is no pathologic diagnosis by biopsy. I'm trying to remember if I had a comparison which shows that this is unchanged. Well, this is 2013. So in looking at the radiograph, we can see there's no apparent change. Sorry, what happened there? Let me just fix that up for you, if I can, to get back to that. So in making the comparison, there's no apparent change. So very consistent with a benign supraclavicular vascular malformation. I don't know what name to give it, maybe just a venous malformation or a strange hemangioma, but Fibrotic, yep. I don't think I've seen one of these before in the soft tissues of the chest that I can recall seeing. I've seen something very similar in the mediastinum as a mediastinal hemangioma, but not in the supraclavicular soft tissues that I can recall. David, ever seen one? You and I have the longest sojourn doing CT reading.
Seen them in the axilla.
I have not seen one. Sorry, I didn't have the microphone
No,
on.
that's okay. You've seen one in the axillary region, Peter, like that?
Axillary and then right upper extremity. We had
Okay.
we read it.
Okay.
Yeah. It was maybe a year or two ago.
And Peter, what did you call it? Did you call it a venous malformation?
Yeah. Exactly. A mass venous malformation.
Yeah. I think I've seen one similar to this in the upper anterior abdominal wall near the liver on one occasion, in thinking about that in the distant past, that we called a venous malformation. All right, let me show you this one. So this is a patient that folks came down to the reading room the other day, and the pulmonary team was consulted on this patient that has recently been diagnosed with acute leukemia. And the consultation was called by the oncology team because of this. And they sort of anticipated that the pulmonary physicians would do a biopsy. So let's have a look at this some more. So let me just get my time. This is August of 2021. And the more recent one I will show you is unchanged. So I could go switch over to this one, which is the more recent one. Okay. So let's just go through this, even with the thin cuts. Well, we can start with the lung. So here we have this opacity in the peripheral portion of the lung. You can appreciate that there's a generalized volume loss of the right lower lobe compared to the left lower lobe. Here is the major fissure. I'll make this a bit bigger, and I hope to show you that, not looking at the opacity itself for a moment, but if you look at the vessels, as I scroll up and down, I hope you get the idea, for example, like this vessel, and the more you look that the vessels are sweeping in around this, they're curling around that opacity. So of course it's round. What's really interesting to me about this opacity is that it's got some aerated lung apparently, so it's not uniformly opaque as such. But then the key thing also to appreciate is that there's pleural thickening contiguous with it. So let me bring in the coronal, because I think the coronal shows the extent of the pleural thickening in that medial hemithorax quite nicely. So there is a fair amount of pleural thickening in that medial and basal right hemithorax contiguous with it. So I certainly assured them with confidence that this is an area of round atelectasis that is formed secondary to the pleural disease, got all the features one would like. A little bit unusual because of some air-containing structures within it. Usually when we see rounded atelectasis, it's usually quite opaque, the entirety of it, but there's clearly some air in the anterior portion of it. But again, I made a confident diagnosis of round atelectasis. Anyone think this ought not to be that?
Yeah, hey, Howard, my
Howard.
colleague Stefan has a comment.
Stefan, I'm Stefan. Howard.
Yes.
So when you see all four components of round atelectasis, round plus atelectasis plus the comet sign plus the pleural abnormality, do you recommend any follow-up, or are you confident enough to call it round atelectasis and just move on?
I am.
Okay, because I'm a little bit of a coward, and I'm probably the only coward then, because a lot of times these people have asbestos exposure and sometimes they smoke, so they're at high risk for cancer. And sometimes I'm a chicken and I recommend a follow-up. I guess I'm the only one.
So I think you can be pretty confident in a case like this, especially if you have uniform enhancement. You got very nice, well-organized vessels in this thing. One of the the striking things about atelectasis is that it blushes a lot with contrast. Now we're pretty early in the bolus here,
That's
so
it.
we've
Yeah,
not
we're kind of early.
enough time. But uniform enhancement is another way to be confident that this is atelectasis and not something scary like tumor or even infection, which is not going to be uniform in enhancement.
Yeah, I mean, it looks like round atelectasis, but like I said, sometimes I'm cowardly and I recommend a follow-up.
Yeah.
Thank you, guys.
Yeah, sure.
Yeah.
I think
If there are any,
look at this.
if there are typical findings, I would think cowardice is justified, but there are no atypical findings in this one.
Yeah. Yeah.
Sometimes I'm cowardly even when there are typical findings. I'll be quiet now.
Oh, you're fine.
You should increase your medication if it helps.
Yeah. Yeah, it's good. All right. So I reassured them, and they were happy with that.
Howard, I think air bronchograms are fairly common in the medial side of the round atelectasis, near the hilum. So you often see air bronchograms on the edge of the lesion, the
Oh,
way
I see.
you've got them here. So air bronchograms are another actually reassuring finding in round atelectasis to me.
If there's air in the bronchi as they sort of enter the lesion or close to the entry of the lesion. Yeah.
Yeah.
The other thing that, let me see if I bring this one up. The other thing that I did see, which is a very small finding, is that I thought that there were some secretions in some of these small airways, but that didn't bother me at all because clearly this area is whorled, it's atelectatic, the bronchi are distorted, and there may be some small airways that are a little bit twisted, and therefore if there's a little bit of mucus and secretions in some of the small airways, that doesn't bother me either.
Including aspiration.
Yeah. Like some of these guys are just little airways that have got sparse amounts of mucus. You sort of get the air and it kind of disappears a little bit, but that didn't bother me either. That's fine. Good. Okay, I'll show you my last case, which I have a surgical lung biopsy of. So these are images from another hospital. So let me show you the 3x3s. And I'll make this big, so I'll just scroll down. So you'll see the patient has got findings consistent with a fibrosing disorder, diffuse. I'll scroll down to give you a feel for the nature of the opacities, the locations of them. It is a little basal predominant, not overwhelmingly so, but there is more abnormality in the lung bases. Words I would use include reticulation, ill-defined areas of ground glass opacity, a little bit of architectural distortion. But to my eye, there's a conspicuous absence of immediate subpleural traction bronchiolectasis and clearly no honeycombing. So I don't know how much of this is collagen and how much is just a cellular infiltrative process, but if this is a chronic disorder, and it is supposedly a chronic disorder, this would be kind of an unclassifiable one in my view. With respect to, if you're asked about UIP, I would say this is indeterminate, and certainly I don't think anyone would use either UIP pattern or probable UIP pattern for this. Anyone make any other observations or comments before I go ahead and put this all together with the biopsy? Oh, the expiration series. Let's see if we have the expiration. Here we have expiration. So this is a volumetric acquisition. We can see there's no lobules of air trapping really. And we don't see centrilobular nodules. So that's the expiration series.
Would you say there's some tiny nodules in the like more on the upper lobes, Howard?
Let's have a look. You want to go back to the inspiration series to look for those?
Yeah.
Okay.
I mean, I already saw what your diagnosis is, but
Okay.
the right upper lobe maybe.
I don't know.
Okay.
Not super easy, I think. I just basically said this is consistent with a fibrosing lung disorder, unclassifiable, and really that's it. So in terms of history, it was really unrevealing in terms of particularly occupations and in terms of an obvious antigen for hypersensitivity pneumonitis. So I'll bring this up alongside, and I'm going to switch over and make this black and white. So here, I'll just let you guys read the narrative here. So we've got, I'll just read out some pertinent findings. A striking centrilobular or airway-centric process, airway remodeling, peribronchiolar metaplasia. There's some mixed dusts. Fairly easy identifiable loose interstitial granulomas, which are located near airways. There's a little bit more fibrosis in the lower lung zones, with some areas here consistent with a UIP pattern. But in talking with this with my pathology colleague, that was not a dominant finding. So you can see the narrative there, more hinting towards something other than UIP. So here's some annotated images for you folks. Arrow points towards some loose granulomas. Here's some in higher power. Yes, there's some dust in there, but we don't actually have silicotic nodules. So here we have some mixed dust around airways, polarizing microscopy there. Again, more in the way of granulomas. This one is a nice granuloma. I can even recognize that as a granuloma. So granulomas were a rather conspicuous feature. Now, in terms of fibrotic hypersensitivity pneumonitis, it's long been recognized that sometimes pathologic findings of UIP may be present, and sometimes some pathologists talk about a UIP pattern in patients with a granulomatous process that they think represents fibrotic hypersensitivity pneumonitis. So that's not terribly surprising. Again, a conspicuous finding was the presence of the granulomas. And there was another image I wanted to show you. Okay, here we go. I'll make this big. As I get more of these path, I can even begin to recognize it myself. So here we have bronchiole respiratory epithelium. And when the respiratory epithelium extends away from the bronchioles into alveolar ducts and neighboring alveoli, we have peribronchiolar metaplasia. Sometimes it's described as airway remodeling. Now, that's not pathognomonic for fibrotic hypersensitivity pneumonitis. It may be seen in other disorders too, but it's one of the things that pathologists do look for as well in patients with airway-centric fibrosing lung disorders. So putting the whole package together, we've decided to label this as most consistent with fibrotic hypersensitivity pneumonitis. And I think the imaging findings are certainly consistent with that, and nothing about them is discordant. Any thoughts, anyone, about this case?
Can you show the imaging again, Howard? Just
Yeah, I'll bring it up alongside.
we can go back to.
I'll just make it big.
So it seems like in the upper lobes again. Can you go back? I thought there was some mosaicism or some patchy ground glass stuff. If you go even farther up.
Okay, up here.
Like these segments right there.
A mosaic attenuation pattern.
Yeah, I mean, like right on in the right up.
Let's see if volumetric axial CT helps us with that.
Yeah.
I don't know. If it is, it's pretty minor.
Yeah, mild. Not super obvious.
Yeah. You know, one can get areas of air trapping in patients even with UIP, so that's not necessarily that helpful.
Right.
If you want to look up a paper in which they analyzed a series of patients with UIP for air trapping on CT, the name of the author is Hochhegger, I think, Hochhegger. Wrote a paper on air trapping in UIP, so you can see it in that condition. as well.
Mhm. Yeah, this is a tricky one.
Yeah. So I don't know how they're going to manage the patient in terms of, the choice between, say, an antifibrotic potentially and immunomodulatory therapy. Is Vasilius online? I want to ask him something if he is.
Yes, I'm here. Hello, Howard.
Hi, how are you? I've
Very well.
read about the one of the studies that sort of addresses the issue of the use of nintedanib in particular is a study. The acronym was the INBUILD study. I can't remember what it stands for. But the INBUILD study evaluated patients with clinical and imaging evidence of a progressive fibrosing lung disorder. And they divided them into two groups based on imaging findings, those with UIP findings on images and those without UIP on imaging studies. And they found that, or claimed that, both groups of patients benefited from nintedanib therapy. So again, these are patients with clinical and imaging evidence of a fibrosing lung disorder. Can you make any comments for us about that general notion?
Yes, from a clinical standpoint, we tend to try at least to distinguish any fibrotic lung disease if it has a progressive or not phenotype. So to be very specific in this case, one way to proceed the patient in terms of management could be to see how he progresses over time.
Yes.
The first step would be to meticulously try and find if he has an inciting agent, because you showed in the pathology slides that he inhaled something. So was into for example, was he a stone cutter, any Hopis, etc. So the first thing, since he has granulomas, would be to try and avoid any inciting agent. And if he does not have any severe symptoms or if his PFTs are within normal limits, one could just wait and see how he will behave, how his illness will behave over time. And then depending if he progresses, there is a lot of ambiguity on this issue, and even experts disagree about whether to give antifibrotics as a first treatment or not.
Yes.
My personal, at least, attitude is try and prescribe in the beginning immunomodulation, and afterwards, if he indeed progresses to a fibrotic phenotype, because at least if you allow me, from my clinical perspective, I wouldn't consider it a definite fibrotic, at least, disease. So I would try initially with antifibrotic, with immunomodulation, and if he develops more severe signs of fibrosis, or if he worsens clinically and or functionally, I would add an antifibrotic.
Okay. Okay. So it's useful to have additional imaging if you have it before this to see whether it's progressed.
Exactly.
Or at least going forward might be worthwhile treating him and then monitoring both clinically with PFTs and clinically look at forced vital capacity, DLCO, look for imaging to see if he's got evidence of progression clinically and imaging wise, and then maybe switch over to an antifibrotic.
Yes, and just a final comment. I think that sometimes I have the feeling that the use of antifibrotics, we tend to overdo it sometimes.
Sorry, that we do what?
We tend to prescribe antifibrotics very easily.
Okay.
and without necessarily having any benefit for the patient.
Right. Yeah, I know it's.
But that is just the personal comment.
Yeah. No, that's very helpful.
Thank you.
Yeah, thank you. All right, folks, we're done for this week. Thanks for your cases, and see everyone next time.